Welcome to Tapping Wisdom. I'm Sue Paternact, and I'm delighted to introduce my guest for today, who is Dean Bernadette Boden-Albala, who is the director and founding dean of the UC Irvine School of Public Health, where she also is a professor in the School of Public Health in health, society, and behavior, epidemiology, and biostatistics. And in the School of Medicine, she is a professor of neurology. So what I wanted to do is speak with you about medical mis and disinformation in public health. So we were introduced last year by a fellow colleague at UCI, and we, realized that, both went from Queens, and we both went to Columbia University for our master's degree. So after you introduce yourself a little bit, I'd like us to talk about the implications of research that I conducted for my dissertation that found that medical and public health mis and disinformation are core sources of burnout for physicians. And that was amplified by social media during the pandemic and it's continuing as since the pandemic. So I'd love your thoughts about the lessons that we've learned from that era and how that informs information management strategies from a public health standpoint going forward so that we can reduce the impact and the influence of medical mis and disinformation on our society. So let me turn it over to you, and thank you for joining us.
Thank you for having me, Sue. I'm really excited to be here. And, as you sort of alluded to, and I have to say, I think that one of the biggest shocks to me when we were living through what I call World War III for us, which was, a massive global pandemic, was there was enough things that were going to be difficult, right? It was going to be difficult to develop a vaccine. It was going to be difficult to make sure that people got the vaccine, that we were able to cover everyone, and make sure that the science was behind us in terms of how to treat COVID and to deal with, especially initially, really the huge amount of death and disability with COVID. But the shock really was that that people didn't believe the science, and that disbelief of science was really coming about from this really malignant misinformation. And if you think about it, we never really achieved more than 70% of the population in the US, even having been initially vaccinated when we had the vaccine. But misinformation was a major player in public health, in how we talked about public health, in how messages were sent, and we just weren't actually able at that point to address all of the issues of misinformation. And I will say, that there's always been misinformation. There's a big anti-vax movement that's been around for a long time. But the percentage of people in that was really small, never more than 4 or 6% at most of the population, and really much, much smaller than that. And usually very isolated groups of people who, if they had gotten transmission, if they had gotten exposed to a virus, really you could have wiped the whole group out because there wasn't any herd immunity in that group. But from very early on, there was this discussion about how COVID really didn't exist. I think we heard, and we'll go into burnout but in a minute, but I think we heard of these unbelievable cases where people were on their deathbed and they still refused to believe that they had COVID. There was fear, there was anger, and a real breakdown of how the public perceived science. And, science is something that we base a lot of the decisions as part of the evidence base on what we do. And we've always done that. We're all here today because we've been vaccinated, because
Sure.
we've had antibiotics, because we have used the evidence base to keep us healthy, to keep us well.
And, and interesting to your point, because it took everybody by surprise that it was so vast. There was some research from the Journal of Experimental Psychology that showed, and it has since been repeated, that the more a mis and disinformation is repeated, the more people will believe it. And people who tend to believe one conspiracy theory will tend to believe others. And the core issue seems to be trust, right? And social connection to the messenger, as opposed, and identification with the messenger, as opposed to the actual objective or source or proof of accuracy. So so like what those motives were obviously nefarious, right? They were not about the good of public health. Yeah. So I think that really took everybody by so much surprise, and demonizing, somebody like Dr. Fauci, who only was about the public good, going back to, finding, vaccines for AIDS. Right.
And that's right. And I think it is interesting to say that when vaccines were finally being produced and the rollout, and I was involved in the Orange County vaccine task force.
Orange County, California. Right.
Orange County, California.
Yeah.
The rollout of that of vaccine preparation and distribution was being discussed. We had a little bit of sense from surveys that we did and others did that 70% of people were going to uptake the vaccine. That was the right thing. That this 5-6% of people were just not going to take it. That was part of the anti-vax movement. But then you had this other 25% of people who were sort of, not sure what they were going to do. And early on, we and others in public health, and of course others in health overall, we said we need to prepare for how we're going to address some of the confusion, concern, the really sort of ambiguity of some of these folks. And, looking back, we did not do a good job. And part of that was because I think that everyone felt that everyone was just going to accept a vaccine. It was just going to happen. And so we didn't spend enough time educating at large and in a comprehensive and lay manner, educating about vaccines, about these new kinds of vaccines, right? Because we changed the way in which we manufactured vaccines, this messenger RNA vaccine. We didn't spend enough time with lay education about that. And so what happened there, to your point, is that bad messages ended up becoming integrated in, and we didn't have a response to those messages. And so we lost people died, and we lost ground in terms of vaccinations, in terms of public health, in terms of science. And what did that do? It's not just about losing ground and losing people, which was bad enough, but that fully impacted the whole healthcare system, which of course was fragile and vulnerable to begin with. And we know that based on the large disparities that we saw in COVID death and disability and long COVID, and really leading to, as you alluded to, I think initially healthcare worker burden, right? And so front line nurses and doctors. I mean, watching people dying and dying and dying. The other day I looked up how many people we lost in World War II in the United States. And the figures are estimating that we lost about 500,000 people in World War II.
In the United States.
In the United States.
Yeah.
And we lost double that.
Yeah.
In COVID.
Yeah.
That's our World War III.
Yeah.
And so,
Yeah.
you know, and I speak to and I know you have too, Sue, speaking to our colleagues in the field, in the emergency room, you know, people who are trained as physicians, as nurses, and people who had specialties, right? They were OBGYN or they were oncology, and they got moved into an area that they did not know.
Yes.
Where we were learning the science as we were doing it, and they were giving of their time, some of them giving of their lives, and people that 30% of people were you know, negative and disbelievers and
Hostile even.
right, and dying and
Yeah.
sick and angry and vulnerable and all of those things.
And their families too, by the way.
That's right.
Yeah.
And leading to this terrible, terrible burnout. And so, you know, in 2022, the Surgeon General puts out an advisory which talks about healthcare worker burnout and saying that this is a major public health issue. That, you know, we know that there's always been healthcare worker burnout in oncology, and that there are debriefings and counseling and, you know, psychology and sessions that a lot of folks in oncology have integrated into their routine to get through this. But we had this, of course, major uncertainty with this pandemic, and we did not really have the opportunity or the resources to put some of those strategies that had worked before into effect. So there's this well-documented toll, again, to frontline workers, but it didn't just, it extended beyond frontline workers. Other research says that about almost 70%, 66% at least, of public health workers report burnout. And so these are people that are not necessarily doing direct, you know, patient care, but are instead in charge of larger programs. This burnout, coupled with other studies, said that nearly half of all state and public health agencies and employees reported people were leaving, shortening tenures, changing jobs in the middle of this. And finally, public health workers have reported increased post-traumatic stress syndrome. So over almost 60% reporting at least one post PTSD, 25% reporting more in terms of post-traumatic stress. And where's that coming from? It's coming from the bullying. It's coming from the non-acceptance of families, of populations, that this is important. And that if we think about bullying and threats and harassment, adding to the burnout during COVID-19, that almost 25% of government public health workers reported bullying, threats, and or harassment. And I'll give you a personal story, which is after COVID had finally calmed down, and it's probably like 2 years ago. So that would be the summer of, you know, 24, sorry, the summer of 22, the public health deans across the country got together finally for their annual meeting in person. And I have to say that we were all traumatized, that we were emotional, that we didn't have, we were all spread out across the country. People were recalling tales of being ordered not to wear masks, of being ordered to come to work during these conditions, of being ordered not to talk about disparities, of being ordered not to talk about everybody needing vaccines, being ordered by other people, leadership in their institutions,
who are not medical professionals at all, right?
Right. And so this is, and so there's no surprise that this burnout leads to people leaving the field and leaving us in a much more difficult space.
And I was reading that another kind of specified form of trauma that's part of the PTSD. We've heard of compassion fatigue, but this is compassion distress. So compassion fatigue is is being exhausted from being so other oriented and other people's
Right.
pain. But
Right.
but compassion distress is having that but being unable to do anything about the causes of that. And
Right.
so I'm hearing a lot of compassion distress about as the Surgeon General outlined, these external environmental
Right.
elements and our social determinants of disparities, our social media, et cetera, that are beyond any one person's control.
No,
That's
and,
so part of the picture.
no,
Yeah.
no, that's absolutely right. And, so the question is, how do we move forward, and where, and so again, some of the distress comes from this very large percentage of the population that of course felt out of control and of course felt vulnerable, like we all felt,
Yeah.
but not recognizing that there were things that were positive that could be done, and instead sort of isolated themselves against the public health infrastructure, against the healthcare system infrastructure, and then causing distress to people that are trying to actually help, working within the system to really move things forward in the right way. And I think one of the problems right now is, where do we so how do we think about the future,
Yeah.
right? One of the things that
Right.
we think about is what does a new public health look like, okay? And one of the things that we're doing here at UCI, that other schools of public health around the country are really thinking about, is how do we give students the tools to counter misinformation? Because it all comes back to misinformation. How do we do that? And who do we do that? And all of our students, whether you're in the more traditional medical healthcare system, you're in a hospital, you're in a clinic, or with a lot of public health folks, you're out in the community. And, Sue, you talked early on about this issue of, where do people get their knowledge from, right? And one of the things that they didn't have to grapple with influenza of 1918, 19,
Yeah.
that we have to grapple with now is social media.
That's right.
And the ability or the inability to make decisions about what's misinformation and what is correct information. And I think part of that is making sure that beyond public health students, that every college student, and then we can go back to even high school students, understands how we gather evidence, understands what that scientific process is, and understands that at any point in the scientific process, there's always going to be some uncertainty, but there's much more certainty. And so that happened, if you think about this whole controversy over messenger RNA vaccines, right? We had actually been doing messenger RNA vaccine work for years. So there was a lot of certainty, but there was always going to be some uncertainty, but you base it on the evidence. And so having a good appreciation of how science works and how lay people can evaluate science is critical. And, so we need to make sure going forward that we're doing that. How to counter misinformation, how to point out misinformation, and how to make sure that we are in the same, that we are talking with people that are influencers of behavior, right? That we are out there, that, years ago, the UN was really trying to work, and we've always had misinformation. One of the reasons that we haven't been able to eradicate polio, for example, and we were so close in 2014 with eradication of polio, but there were still small groups that we just couldn't eradicate it. And a lot of it was misinformation. A lot of it was sort of linkage of, certain populations not trusting the United Nations, not trusting UNICEF. But identifying who the trusted person was in
Right.
the family or the community, and
Yes.
working through that trusted person. And so, one thing that the UN did with polio vaccines was took away anything that on the vaccine that said that it was, brought to you by the UN, and instead, in the community is coming across from the mayor or from the town leader, people that are trusted. We also learned that, again, in polio, that grandparents were
Yes.
really positive influencers. And if
Yeah.
we could explain the science to grandparents, that the grandmother would make the decision, yes, my grandchildren need to be vaccinated. And so I think that there's a lot more work that we can do in public health to really understand who in families and communities are the people, as you said, that are being listened to,
Yeah.
and targeting those people. We started out poorly, even in vaccine delivery, where in Orange County, California, for example, and I'm sure that this is the norm in a number of counties, that initial access to vaccines was through a whole complicated registration system, which was
Yes.
only in English. Okay.
Yes. I
And it
remember.
was burdensome, it was onerous, and people had
Yes.
to work with other people to get vaccinated. And so we have to remember that when we're delivering something, when we're providing new science and evidence, that it has to be equally accessible and lay friendly, to make sure
Mhm.
that we're not off the bat alienating
Yeah.
people who could use that alienation and say, see, we don't trust this, because this is really only in one group or another. So
Yeah.
again, education is critical. We need to have people who are really thinking about technology and how to identify for populations, where this misinformation is, and to call out those folks right away. Again, the scientific process. I've said this, Sudi, before. I think we need to have a defender of science at every Thanksgiving table across the country every year, because science is going to continue to play very big in our lives, whether it's vaccines, whether it's climate change, et cetera. And the only way, and I'll sort of end this, but the only way that we're really going to be able to do it, and sort of sadly, if we think about resources, because that's the other way, right? So content needs to be translated into many different languages. It needs to be accessible. So in other words, it can't be so complicated
Right.
or confusing that people are
Yeah.
just gonna look at it another way. We should be using imaging much more than dense, packed in paragraphs. And this takes money. And so where's that money coming from? Well, if we think about public health in our state and local government, clearly there's money that's coming out of the federal government, but it's very, very little. And there's huge disparities in how much money public health is given at the state and local level, or by the state to the local level. And so one of the things that we have to all be really aware of is, how much money is coming to the resources that we need to be able to translate into lay and accessible information for all of our communities to have. And the per capita money is so different in some states. It's the District of Columbia, it's almost $400 per capita for public health money. In states like Mississippi and Missouri, it's $7 per
Oh
capita.
my gosh.
Right.
Wow.
So we have these huge disparities by state. And so this means the power is in the hands of the people to make sure that we are getting the resources that we need, that translate ultimately into better health and well-being, into really promoting health, promoting public health, so that we don't get ourselves into a circumstance where we've got, huge health disparities, and hand in hand with that, huge healthcare worker and public health burnout.
Yes, absolutely. So it almost seems like if I were to kind of encapsulate this message, what needs to be done is science informed, but not necessarily scientist delivered,
Right.
right?
Right. That's
So,
exactly.
and engaging the community is in a proactive way to be ready for, and I'm picking up the implication that just because we came out of the last pandemic doesn't mean that we're done, right? So
No.
there very well could be some other public health emergency that
Well,
may look or not look like COVID, but there certainly would be some sort of public health emergency. So how does one, how does a society prepare for that in advance? So let's talk a bit about the role that you envision the School of Public Health playing in that, just as a model, as an
sure.
example of what schools of public health around the country, may be doing, and how um, different sectors of the community could be partners in that endeavor.
Excuse me. Yeah, no, I think that's absolutely right. And I think one of the things that I'm most proud of here at UCI and with UCI Public Health is that all of our faculty and our students understand that we cannot do public health without the community.
Yeah.
And one of the things that we do here is really we're training our students and partnering with communities. So even as part of student training, that we are out there in communities, working with communities, listening to the needs of the community, listening to how the community is responding to everything from, lead in soil, climate change, vaccines, chronic disease, and then also supporting the kind of programming that the community really needs. And so community
Yeah.
health workers, for example, as this model to liaise between, the academic ivy tower, the scientist, as you said, and the community,
Yeah.
the community health worker sort of bringing it home and really being the translator of information out to community. And because the community health worker is from the community, they're more trusted,
Yeah.
and really explaining that. And then the community health worker model, getting the community to advocate, providing data. One of the things that was really exciting and I think very effective during COVID here at UCI was, the community wanted data. They wanted to understand how they were being affected. And this is early on, pre-vaccine, by COVID. Who in their community, how many people in their community had COVID? And what did that look like? And, there was a lot of pushback from government about giving people data. And then this is de-identified data, but data. And one of the things that we did was we were able to work with community and community leadership and provide that data. And the community used that data to advocate. And early on, one of the things that the community advocated for was more testing sites, right? Because it
Yeah.
looks like nobody has COVID in a community if nobody's tested, for
Right.
example, right?
Yeah. Yeah.
And we ended up then doing a huge amount. We did the Orange County, California, surveillance early on in COVID, and we found our rates of transmission were very high compared to the few surveillance studies that had been done before. So this is
Yeah.
early. This is like,
Yeah.
May, June of 2020.
Yeah.
And we also found very early on that there was a huge disparity in who was getting COVID, with higher numbers among our Black communities, among our Latinx communities, and even among our Asian Pacific Islander communities. And so public health is really about working with communities and, and understanding the ways that we can get information out, being a trusted source. Really only when we're partnering with communities can we do that, right? When we're in the community and understand, we learned a lot from COVID, and we learned a lot because of our communities. So, we really had essential workers. Remember the whole essential worker, everybody else was sheltering in place. We
Yeah.
had essential workers. They were food workers. They weren't just healthcare workers, but they were food workers.
Or
They were, working in industries that were supplying a kind of essential needs. And so, but what we didn't do well in that, which we learned, is that we didn't make sure that these very essential workers that we were depending upon for our basic needs had adequate masking, had
protections,
adequate testing, and were actually adequately able to be quarantined, and instead went home to large families where transmission was rampant. And so, so only by working with communities and understanding the needs of the community can we really move those things forward. And so those are the kind of things I think we need to do. And I will say, whether it's infectious disease, I think we're going to be hit with a lot of health consequences of a changing climate. How do the elderly handle many more high temperature days? You and I looked out the window today. We're having a bad air day.
Yeah.
People with asthma, people with COPD. And so we need the science to be translated into communities so that the action to reduce poor health is actually taking place.
Thank you. Can you give us examples of members of the community that you did work with? Are we talking about churches, nonprofits, schools?
Yeah,
Yeah.
absolutely. So we worked with schools early. In fact, I think it was that summer of 2000 and summer maybe 2020. We worked with schools. We worked with students in high schools. We talked about a lot of different issues around COVID, everything from race, ethnic disparities to cutting down on transmission, to the importance of testing and anticipating vaccines. So we work with schools. We work with organizations like Latino Health Access and OCAPICA that were really grassroots organizations that were providing ongoing services into community, working with them to see if we could help enhance programs, if we could get over some of the stigma and barriers around vaccines, and around testing early on. We worked with the Orange County Healthcare Agency, and helped them with translation, helped them to build a more accessible public website for vaccines. And so worked with police, worked with fire, really worked with the whole, and worked, I would say, with small businesses and large businesses, because businesses and industry are a great place to make sure that we're practicing good public health, worksite wellness, and providing information that extends outside of that workforce and into families and communities.
Sure, whether the heads of human resources or the chief medical officers, if it's a health organization, et cetera. Yeah,
Exactly.
Makes sense. The way I like to end these kinds of interviews, Bernadette, is I like to ask a question that I learned when I was in the journalism industry, which is, what have I not asked that would be helpful to know, or you would like to just share with our listeners?
Wow, you've asked me a lot of questions. I think that I think one of the things that I would really like to say is that, public health is not just a group of people that are trying to optimize health and well-being, that public health is really for all of us. It's about all of us, and that all of us need to be part of that conversation. And only when we're all part of the conversation can we really move things forward. And so we need to think about, and we are in a big election year, and I think that we all need to make sure that health, that public health, that optimizing health, that everything around health and health workers and resources is in place. And so don't be afraid, whether it's local or state or national, don't be afraid to ask the health questions, because at the end of the day, if we look back over the last 5 years, health was really the number one thing that changed our lives and impacted us. And it should be part of all of the discussions of the people that we decide to elect.
Yeah, absolutely. As my grandmother used to say, if you don't have your health, you know, nothing else matters, right?
Exactly right.
Right? If
That's
you don't feel
exactly.
good, nothing, if your body is failing you, nothing else matters. We could continue this conversation for quite some time, but I think this is a good place to thank you so much for sharing your wealth of information, your insights, and your wisdom. Dean Bernadette Boden-Albala, thank you so much for joining us. And thank you everybody for listening. This has been Tapping Wisdom. I'm Sue Paternack, and thank you again.